Hi, everyone. Welcome back to Healthcare Friday afternoon, 1:15-ish. We're going to take a break from budget for a little bit. And if you remember, I had asked everyone to send in their priorities, should we have time to take up more bills, which everyone did. Thank you. And so we did top three. The first one with the most votes was the one we're going to hear on today, H741, an act relating to health insurance coverage for colorectal cancer screening. The second one was H818, an act relating to establishing a mental wellness and climate resilience pilot program. And the third one was H621, an act relating to health insurance coverage for diagnostic breast imaging. They got a total of 4, 4, and 3. Then there were 4 that got 2 and a bunch that got 1 vote.
Who voted?
We all voted. Remember when you sent your recommendation,
Top three
top 3 bills, the tally
of what was left over here.
of what was left over there. I am gonna say we're quickly running out of time before crossover. So we're gonna hear 741. We had 621 on the agenda, but I asked for it to be taken off because we have to finish the budget. That's our priority. Next week, we have to, or we're gonna try to finish and vote whether or not we voted out or not, but no story. 721, which is Medicaid expansion, 766, which is provider burden bill, and 233, which is the PBM bill.
Next week?
That's the hope. If we don't, we still have 1 more week when we get back before crossover. So I think with all of this to say, we'll do what we can for these other bills, but there's limited time. And the ones on the table are their priority at this point. Does anyone have questions? Art? Who else? I just look at you two.
Mine's pretty quick. Would you send me the email where you asked for that? Because I don't remember voting.
Oh, yeah, no, you sent me, I will send it to you. You sent me your priorities of bills you wanted us to do.
Right.
And then I tallied all those votes. I tallied all the votes that people came to me, like what their priority bills were. I can send it to you. Said what went to the top. That makes sense.
I don't.
You didn't vote on it.
What
I did that.
You told us in here.
I sent you an email too.
You did?
You mean the summary? You didn't send a summary email.
I have not sent a summary
So we
update.
never
I
saw-
don't remember ever voting. That's the only, that's my
That
only.
one
I sent the email you sent me. How's that?
Oh, I know I sent that email.
But that was the vote. That was the
That
vote.
was
He just tallied the numbers up.
You tallied the numbers.
Oh.
So we never came back to vote on it.
Just how many put
Yes.
those things in?
Yes.
Oh, gotcha.
Yes, exactly.
Misunderstood. I thought we had a list and we had.
No.
You're still doing maple syrup.
So anyway, Leslie,
So one of my curiosities was, we had 3 bills related to health prevention, screening, Could we combine them into one bill?
so if you remember, some of our concerns around screenings, anything, that involves like insurance covering something, is we have to determine whether it requires us to cover it with general fund or not. So I would like to keep the bills separate.
Okay.
For that purpose. My plan is to hear 741. Excuse me, and send it to the insurance companies and DFR to say, in fact, I've already sent one of them, it might be 741, for comments on whether or not they think this would require us to fund it by general fund dollars versus.
Yeah, one of them was pretty vague. It didn't say, one was more vague than the other. I don't know how it was written. Whatever, it doesn't matter.
So anyway.
The third was 671. I think I got the number wrong.
741, 818, and 621.
620, sorry. Thank you.
Is that 621 is the one I sent the question on? Okay. Okay, great. So that's where we are.
Guys, late.
No, that's okay. We just said, you remember when I sent the request out to like everyone prioritize their top three bills? The first one was 741, which we're gonna hear about today. The second was H 818, and then H 621. And just a reminder that we have next week and then one more week after crossover for any bills we want to get out. And then just after crossover, after that week, we tend to be on the floor that next week a lot. So just keep that in mind. We'll be taking up what the Senate sends us. And then we do have other things like we're going to do a deep dive into workforce. We are going to next week look at our CON process, certificate of need process, the history of it, what is required to do a CON, and then hear from witnesses if we should be looking at altering that process. I've heard from various people in the healthcare world that, you know, it was written a while ago, maybe there should be some updates. So I do want us to look at that. I think that's important. And then squeeze in what we can. I'm good. Any question? Okay, great. Okay, would you like to join us? Representative Kate McCann. Welcome. Thank you.
Hello. For the record, I'm Representative Kate McCann from Montpelier. Thank you for considering H 741. As most of you know, this bill is very personal to me. My journey with colorectal cancer began just days before I was elected to the legislature. In 2016, at age 42, I had my first colonoscopy as part of a larger medical procedure. In 2022, at age 48, because it had been 6 years, and because my younger sister had been identified as high risk for colorectal cancer, my primary care provider ordered a colonoscopy scheduled for late October. I can remember coming out of anesthesia and hearing Dr. Asnes imploring my husband to ensure I follow up with my primary care provider. It sounded alarming, but I had no idea what was to come. Days later, the pathology confirmed colon cancer. Days after that, an MRI would show that the cancer had spread to my liver. At age 48, I was diagnosed with stage 4 colon cancer. The prognosis from UVM Medical was bleak at best. I was told that I was not a candidate for surgery, and the course of treatment would be chemotherapy until my body couldn't take it anymore. I began chemotherapy with UVM Oncology and sought a second opinion. Memorial Sloan Kettering called me the Saturday after Thanksgiving. One of the questions from MSK was what insurance I had. I answered with Blue Cross Blue Shield of Vermont and was told that I was in network. As a public school educator, I'm very grateful for the Vermont NEA members that negotiate health insurance on my behalf. Having really good insurance when you need it the most is critical. MSK said that they would cure my cancer, and over the next 12 months, I first completed the initial round of chemotherapy. I had surgery in March of 2023 to remove the primary tumor, chip away some of the liver tumors, and place a hepatic artery pump to allow targeted treatment to my liver. Then I completed a second round of chemotherapy. I had a second surgery in August 2023 to remove all remaining liver tumors. They took about 30% of my liver. I'll add that my roommate at the time was a 27-year-old woman with stage 4 colon cancer. I then completed a third and final round of chemotherapy. I'm very lucky that the cancer spread to a regenerating organ and that my body responded so well to the chemo drugs. I'm so very grateful for the coordinated care at Memorial Sloan Kettering. Just before Thanksgiving 2023, I was told that I was tumor and cancer free. H 741 proposes to align Vermont's health insurance coverage requirements for colorectal cancer screening for individuals at average risk for colorectal cancer with the most recently published recommendations established by the American Cancer Society. This bill would expand coverage for those at average risk and maintain the current coverage for high-risk individuals. Under current statute for insureds who are at high risk of CRC, the benefit includes colorectal cancer screenings, examinations, and lab tests as recommended by the insured's treating physician. The American Cancer Society Cancer Facts and Figures 2024 report demonstrates a need for expanding coverage for those at average risk and maintaining current coverage for those at higher risk. Of all cancers, colorectal cancer will take the most lives of people under 50 by 2030. 1 in 10 colorectal cancer colorectal cancers are diagnosed in patients under 50 years of age. 1 in 26 women will be diagnosed with colorectal cancer. Those with a family history of colorectal cancer are at higher risk and need to be screened earlier than 45. Colorectal cancer is preventable with screening, and affordable take-home options exist. There are more than 20 million Americans eligible for colorectal cancer screening who have not been screened. The CDC estimates that 68% of deaths from colorectal cancer could be avoided if all eligible people got screened. Black Americans are about 20% more likely to get colorectal cancer and about 40% more likely to die from it than most other groups. Less than 50% of Asian Americans are up to date with colorectal cancer screening. And Indigenous communities have higher rates of colorectal cancer. Jews of Eastern European descent have one of the highest risks of colorectal cancer of any ethnic group in the world. And by 2030, the incidence of early age onset colorectal cancer diagnoses under age 50 is predicted to increase by more than 140%, meaning that more than 27,000 people under age 50 will be diagnosed with colorectal cancer. In closing, research data is what drives official recommendations on screening age. As more data becomes available, recommendations can change. The current screening age was lowered to begin at age 45 instead of age 50 in 2021. We must act now to bring Vermont law in line with science-based recommendations. If you were to decide to take up this bill, I'll add that I'd love to see a friendly amendment included to say, on the average risk side, ensuring that a colonoscopy after an abnormal non-invasive test is also covered without cost sharing, which would be aligned with federal statute. Thank you very much for taking my testimony today. I'd be happy to attempt to answer any questions, perhaps following the walkthrough with Ledge Council.
Okay, thank you
Very much.
Sorry, congratulations.
Thank you. What a journey.
Zoom. Great. There. All right. So good afternoon, Jen Carby, Legislative Counsel. Here is H 741. And as sponsor said, this is a bill, an act relating to health insurance coverage for colorectal cancer screening. There is a requirement already in Vermont law that colorectal cancer screening be covered by insurance, and this has been in our law for a number of years, so it was included in the benchmark benefit package when we were talking about state defrayals recently. So I don't believe that that this would constitute, would want to confirm with DFR and DVA, but I don't believe a change like this, to the extent it even is a change from current practice, would require state deferral, but we will want to confirm that. So under current law, insurers have to provide coverage for colorectal cancer screening, including provide someone 50 years of age or older with an option of an annual fecal occult blood testing plus 1 flexible sigmoidoscopy every 5 years or 1 colonoscopy every 10 years. This would replace that and say that for an insured who is at average risk for colorectal cancer, the screening examinations and laboratory tests would be covered in accordance with the most recently published recommendations established by the American Cancer Society for average risk individuals. And then, as the sponsor said, it would keep the language for individuals who are at high risk. I think that is it for the changes, other than the effective date. It would take effect on January 1st of 2025 and apply to plans as they roll out over the next year, but in no event later than January 1st, 2026. So a couple of things I want to mention just by way of context, and I think if you decide to take this up, it will be important to hear both from the insurers and from DFR and DVA. Under our existing law, and this is in two places, so I'll just show you one. There is a requirement because it copies what's under federal law, which requires that a group insurance policy, and in our exchange statutes, it's for the exchange plans as well, policy not impose any co-payment, co-insurance, deductible, et cetera, and one of these is preventive services with an A or B rating in the current recommendations of the U.S. Preventive Services Task Force. So I'm going to take that down so that I can show you what the U.S. Preventive Services Task Force is recommending. Now, I believe the recommendations largely or entirely currently align between Cancer Society and the U.S. Preventive Services Task Force. It doesn't mean that they always align that way. But this is where I think it may not even be much of a change. So here we are in the U.S. Preventive Services Task Force under colorectal cancer screening. And you can see that for adults 50 to 75, having screening for colorectal cancer has an A rating, and for adults 45 to 49, it has a B rating. So for those groups, at least, it is currently required under Vermont law that there's no cost sharing associated with that. How all of those pieces line up as far as what is required to be covered, what is required to be covered without cost sharing, and how that's been implemented in existing plans is, I think, is the piece you would want to get testimony on, in addition to how you want to tie Vermont law to something outside of the state's control, which we sometimes do, but I think less frequently with an organization than with a governmental entity like the U.S. Preventive Services Task Force. So those are all
Tied to
considerations.
today.
You don't tie it to anything today. It's based on age, I think, and so the age limitations in our existing statute seem out of step with the recommendations both from the American Cancer Society and from the U.S. Preventive Services Task Force, which means I don't know if, because of some of the requirements under federal law and our state piece tying that in, is that already happening? How is that being implemented at the state level?
Melanie and Mari.
Is there anything that defines high and average risk anywhere in our statute?
I don't believe so, but give me a minute to look specifically for this one. I don't know. Hold on a second.
Yeah.
I don't want to get out ahead of myself here. No. Yes, sorry. See, I knew I was getting out of myself.
Federal.
No, it is. So let me put this one up. So it's just not done as a definition. That's what threw me off for a minute. So for purposes of that B2, which is insured at high risk, and insured is at high risk if they have family medical history or genetic syndrome predisposing them to colorectal cancer, prior occurrence of colorectal cancer or precursor polyps, prior occurrence of chronic digestive disease condition like inflammatory bowel disease, Crohn's disease, or ulcerative colitis, or other predisposing factors as determined by their treating physician.
That's the high risk.
That's the high risk category, right? And so some of that,
Average risk we would probably have to define.
I think average risk is not that. I'm not sure anybody is at low red. I
Oh, all right.
think being alive maybe.
Yeah.
Average.
I like that.
And my other question is, and you may know, Lori, what cohort of people would this apply to? Everyone in the state who has insurance, or is it that 7%?
And as usual, it is the people we can affect. It is the private and privately insured. So the exchange, individual and small group, and to the extent there are fully insured large group
Right,
plans,
okay, that's what I thought. So,
as well as, state employees and teacher plans.
okay, so it would be that, but not the larger piece of the pie.
Right, it's not, under this piece and under what you're doing, you can't reach the self-funded
Yeah,
large
yeah,
employers.
Yeah,
There are some of the federal requirements will reach them though.
thank you.
And so I just want to follow up on this US preventative thing with A and B. So that's the federal requirements?
That is those are federal requirements. The A and B rated services is a requirement that was enacted in the Affordable Care Act, and Vermont enacted those same provisions under state law 5 or 6 years ago when there was some concern about the future of the ACA, to have those same protections, certain protections in Vermont law, as well as relying on the federal law.
So then I'm confused. So why is this not covered if I'm missing something?
So the law that we have about US Preventive Services Task Force is about cost sharing.
Oh, right, cost sharing only. Okay, got it.
So yes, and so I believe there is a coverage requirement embedded somewhere in the ACA that applies, but I can't point directly to it. I think, and I think some of it is through the benchmark plan. I don't know what the standard is in the benchmark plan. So this is where I think you need to get some more testimony.
Okay, Melanie?
Is there a definition that, for colorectal cancer screening or the laboratory test? Because that's different than colonoscopy, right? There's more than just colonoscopy. Is that included in the definition?
No, the only terms that are defined are colonoscopy and insurer. So we could certainly
we could
look at whether
see
there
if there's
needed to
others.
be,
It's-
yeah, we could look at whether you wanted to put, let me look at what the bill language says. Yes, although, with the language that is in the bill, depending on what the American Cancer Society's recommendations look like, they may describe, so it says to provide coverage for colorectal cancer screening examinations and lab tests in accordance with the most recently published recommendations from the American Cancer Society. So if those detail what those screening examinations and lab tests are, then I think they would be incorporated by reference.
I just want to make sure everyone knows what we're talking about. So there's like Color Guard is a name of something.
Cologuard.
What is it? Cologuard. And so you could do that very inexpensively, but then the question is, if something comes back and you have to go in for a colonoscopy, is that now considered screening or diagnostic? And that,
I think that's a piece of it. I think it's also looking at the age,
right, and the age.
the age level and options beyond fecal occult blood testing and flexible sigmoidoscopy. There may be, other developments since this was initially enacted, which I think I also wrote, but 2009.
Hold on, Art Mario was next and then we'll go.
Couple comments, then a question and or recommendation. First, thank you, Representative Buchan. I'm glad that you're here to share this with us and make things better. And I am very interested in seeing if we do move forward with this bill, adding your recommendation. My question is on page 2, the existing language, line 12. Is this a place where we can replace physician with licensed independent provider? There may be physician assistants and nurse practitioners that perform that procedure.
So I think this is certainly a place that you could expand the provider types, and we could either, define a term and use that term, or we could expand the list. I think it comes up a couple of times, so it may make sense just to define healthcare professional and then say who's included in that.
So I can reach out to colleagues. I think LIP is the accepted standard phrase, but I can get
What is LIP?
licensed independent.
I don't know what it means to be independent. That's not a term we use in statute. We have a lot of healthcare professional, healthcare practitioner, and healthcare provider, and then we define them to mean licensed under the applicable statutes.
Okay. That's just the medical
Yeah,
phrase
Okay,
for, it's not just physicians.
that part's fine. I think it's fine to expand that to include other provider types who are within their scope of practice to do that. Absolutely. I think some of that is a relic.
Yeah. Figures.
anything else for Jen? Yes, you did, so.
I just want to be clear on the language on page 3. So average risk, everybody seemed to think was that wasn't high. So what this does in effect is just remove the language, the age limit, so that anybody could get it at any time.
Yes, and I think it potentially expands the type of screening and testing that would be covered and the frequency with which it would occur. So for example, this currently says they have to cover at least for somebody with, taking out the H piece, one colonoscopy every 10 years. If those aren't the recommendations from the American Cancer Society, that could become more frequent than every 10 years, could be every 5 years. As to your average risk piece, I think there certainly is, we could also just say for an insured who is not at high risk, and then it's everyone who, if that feels
Yeah.
better than using a term like
Well, I
average
don't know. I'm
risk.
just trying to get my head around what this does to it. That's all.
Yeah.
I'm just trying to understand.
Yes, and some of it is hard because I think there's more going on in the healthcare legal space than what we have that affects this kind of coverage than the words in our current statute. And so I think we need to hear from others about what the picture looks like. Yeah,
Right.
so then you can decide what changes you want to make.
Yeah.
If any.
Questions for Jen? Thank you, Jen. Any questions for Kate? You don't mind, Kate? I actually have a question.
Okay.
First, thank you again for coming in and sharing your story. We're so happy that you're here and doing so well. I'm curious if when your doctor, I think the timeline was you had a colonoscopy and then 6 to 8 years later, they recommended another one. Do you have to get a prior authorization? Do you remember for that? And if you did, was it approved or did you not? And they just said, yep, your provider says you need one, so you can go. Remember?
I do not remember,
Okay.
but I also don't think so.
Okay.
And I am in tight conversation with my primary care provider, so I could find that information out.
Okay. Yeah, but no, that's fine. I was
But
just-
I don't think so because because I had one previously.
Previously. So you were already in a category because of your sister, so, okay. Great. Any other questions? Great.
And I
Thank
hope
you.
that I answered your question through that email
Yes,
on that last piece
Yes.
about the at higher risk part, so.
great, yes, great.
All right.
We will
Get it back
let
to
you
you.
know.
you so much.
Thank you very much. Thank you very much.
Thank you, Kate. All right, folks. We are in the home stretch. Okay. 2 things to do. First, we're gonna turn the page over. Start on the back side. Maybe that'll make things go faster. So we will be updating the Vermont Care Partners line with the correct numbers, all of that good stuff. But now we have these 4 category, 5 categories of reimbursement rates. With one, we have not actually prioritized. So I want to remind everyone, because I made it more confusing than it probably had to be, that I changed our 1, 2s, and 3s to better reflect what we did last year and to match what Human Services is doing. So anything we did a priority 1 is considered highest. Anything considered a 2 priority is high, and medium is 3. So when we look at those reimbursement rates, we had voted, ranked visiting nurses associations and EMS as number 1, so they are now highest. By state, FQHCs was high, so they were 2, so they're now high. And Vermont Medical Society Health First was a 3, which is now medium. Now we need to put Vermont partners into this. I am happy for these, because there aren't that many, to open up the ranked choice voting again. Or we could, I don't know, I'm open to suggestions. I'm getting tired.
Review the money just so we have it in the front of our heads for.
Yeah, so
Vermont Care Partners.
it's about 3.3 to 3.4 million state dollars.
In the general fund.
Yeah.
Yep.
So you want us to rank these 5?
Well, so the question is, we've ranked 4 of them, but now we've added a 5th to the mix. So is it just easier for us to rank the 5 again?
Oh, I see.
Or if
You
we,
wanna move this up in the order?
right,
Julie, yeah.
like where do we want to put it in the order, Maury?
I remember what the last increase that we gave them in Medicaid rate increase, what was that?
4%.
And that was last year?
Mhm. And remember, 1.5 of this 3.3-ish, we're taking from the embedded mental health work. So we are providing some funding for
So the whole cost would be 5, whatever.
no. The whole cost is 3.3,
Oh, so
but
but the-
1.5 of it is coming
So it's
from,
really actually, what we're asking is for 1 point whatever.
well, we're really asking for 3.3 because they may
But
not,
we're offsetting it with that other
we're
amount.
offsetting what, if they
buy
choose
it,
that.
yes.
Yeah.
So I just want to be sure I understand that we're actually asking for 1 point something or other, because I don't know, they will, but I do.
Yeah, if you buy into that, yes, we were asking
I buy
for,
into that,
we were asking what's 3.3 minus 1.5,
yeah.
whatever that number is.
So we've got 2 highest.
Mhm.
And that, unless we want to change one of those, we keep those 2.
Yep.
We got highest and medium,
Mhm.
so now we want to put the Vermont Care Partners in one of those.
Or not. I think we're gonna, go ahead, Bob.
Oh, no, I just feel like I must have missed something about where we went from 6.5 down to the 3. Is that because of human services? Am I correct?
So the DA's SSA's asked for a 6.5 Medicaid rate increase. And we suggested 3 because Teresa and I, the chair of human services, and I had talked. And that's what they were considering, and we try and stay equal.
But that's, I just, that's what I got, but I wanted to make sure that was still,
Yeah,
my memory was correct.
yeah. And Alan, I'm sorry, I might have cut you off.
Oh, no, it's okay. So we've got to put a title to that one, right?
We have to put in, yes, we have to rate it,
Okay.
rank it,
In that category of those 5.
yes.
So if we wanted, if say we did want to go highest, we take one of those off.
We don't have
Because
to,
you're only going to put 2. Oh,
we don't have to.
oh.
You can do whatever you want.
I'm here to tell you.
Sorry, Lori. Well, I'm really tired, Lori. All right,
I want to understand Vermont Care Partners Medicaid rate increase. So how much do they get? What is their percentage of? Is that we're talking percentage of Medicaid?
it's,
They
so
get-
this is done differently because they're given and Daisy, you can probably explain this better. Amy's in the room. So it doesn't equate to 100% of Medicare like the
Okay,
other ones.
that's what I was trying to, it doesn't? Oh,
No.
okay.
No, it basically equates to, if we say 3%, we know the number that is gonna be versus 100% of Medicare. Medicare can go up and down, year over year, so.
Right. Okay, so
So we know it's three.
It increases the whole amount that they would get.
Yes. It increases the whole amount that they would get each year by approximately $3.3 million in state funds, but it's grossed up.
Right. Okay, so it's just a bulk amount of money instead of a reimbursement.
It's still based on reimbursements, but that's,
All right.
but basically it's adding to
I got
what they
you.
get.
I got you.
Yeah. And again, I'm gonna go back to kind of why I originally proposed this idea to take from one to give to the other, and for what the DAs and SSAs do is, we have a mental health crisis. We're really working hard. I think we're making great strides. But we have a system of care in place, and that's where we should be investing our dollars to help the mental health crisis.
And
That's what I think.
it's a strategic investment.
Yes.
Like, I'm really enamored with that idea. I'm enamored with putting this, I'm just gonna nudge this along because I'm really tired too.
Yeah.
I really like the idea of putting this as my highest,
Fine.
because, the mental health system of care is so underfunded traditionally, historically. And we need to, support those providers. I would do it double this if we could, but we can't. But I think that the creative strategy that we used, thank you, Lori, to come up with the 3.3 million, in collaboration with Human Services. I mean, that's ideal way of solving a problem when you're low on resources. I think
Yeah.
this is fantastic, and it's my top priority, above VNA, which I just call it the third highest, like it's the first
Okay.
of the three highest.
Okay.
For me.
So let's do this. So everyone's gonna tell me if they want it compared to the others, if they want it medium, high, or highest. Daisy has said highest. Alyssa adds it to the high category.
I'm gonna add it to the high category.
High,
I'll go by.
high,
Not me.
high,
Highest.
highest.
And can I speak to it?
Sure.
And the only reason I'm going that way is because of the up and downstream effects of being able to move people out of hospitals and keep people at home as they are sicker. And I think I'm just thinking about that piece of the puzzle. I mean, I want that piece too. But I'm just thinking about the broadness of the impact. And I'm just hoping that, we alleviate ERs and we alleviate primary care, or we get people more, I just feel like it have more impact.
Alan and then Bob.
I've said this right along, and the visiting nurses to me is very dear.
Yeah.
I don't know if people around here realize in a rural area how it keeps these people home
Yeah.
for palliative care, end of life care. And I don't know if we really know the impact that what it saves the hospitals.
Well, I never actually got to report back to you guys about what I heard in the Ed Committee about what was going on in schools with mental health services. And I don't know if it would change anybody's votes, but the biggest thing was that needed more help from the DAs, and they weren't able to get enough. There was too much of a waiting list, and
Yeah.
they have so many students with acuity levels that are through the roof. So for that reason alone, I feel like I need to put the DAs at the highest, even though I don't want to lose the visiting nurses or the EMS support, but it's also those are small compared to the amount of money we're talking about with, the DAs.
Okay.
But I would like, for what it's worth, I'd like to put that at the highest category.
Okay. So you're highest. Melanie, you're high. You're high. You're high. You're highest. You're highest.
What are we talking about? Sorry, are we talking about visiting nurses?
No.
Oh,
No,
no,
we're talking
okay.
about Vermont Care Partners.
I thought you pointed at me and said highest.
Yeah, I'm verifying your
It's
vote.
not like
I'm
that,
verifying your vote on the DA's SSAs.
not highest.
You just said it was.
I'm sorry, my intention, sorry, Friday for me too, was to keep my highest at visiting nurses, and that's what I was speaking to.
Okay.
Sorry.
We're going to start over.
All right.
Thank you, Leslie, for clarifying that. Topper's going to be like the second guy in charge and
Damage control.
make sure you do it.
Aye.
Yeah, we're talking about,
The Vermont Care Partners.
thank you.
Vermont Care Partners, high.
Thank you. I need it.
Bobby,
Probably highest.
Highest,
Yeah.
Art,
Aye.
Hi.
Aye. Oh.
Super high, highest.
that's not a category.
Highest with the B&A also being highest.
I thought you were.
okay, but we're only voting on one.
Yeah.
So you-
Again, I have to be a problem.
you got-
There's no wrong
I'm
answer.
doing it
There's no
high,
wrong answer.
I'm doing it high.
Alyssa was a high.
Alyssa was
Highest.
Brian is a highest.
Highest, Brian? Okay, what about you?
It doesn't really matter where I go because high wins.
High wins.
So we're gonna put high with, so we have two highest, two highs, and a
We
medium.
had 3 highest.
I'm sorry. On the chart,
Yes. I got
we're
4.
all having a little trouble.
I got 4.
Yeah, so what we have is we
Waiting for
have,
that joke.
in our priorities, we have visiting nurses is highest, EMS is highest, Bi-State is high, Vermont Care Partners is high, VMS is medium.
It's based on the tab above.
Yes. Yes. You agree with that?
Yep.
Yep. Okay, now. Last year, we actually ranked. We had doubles. I am not doing that this year. Thank you. So now we go back to the turn the page over and we're going to the bundle. So I would like to make the following suggestion, which came from Melanie. So first, so right now we have everything's 1, 2, 3, 4, 5, 6, right? So we need to convert those to highest, high, and medium. So the suggestion is a 1 and a 2 is considered highest. So it'd be 2 highest. 3 and 4 is high. So there'll be 2 highs. 5 and 6 are mediums, there'll be 2 mediums. And we do the same thing we just did for the 2 we're adding.
One number instead of.
No, give them a highest, high, or medium.
So we're
You got
gonna,
3 choices on all.
yeah, you have a highest, higher, medium.
Could we take it
You have
off?
a most high.
Or could we take it off? You don't?
You can choose that you don't want it.
Yeah, I'm gonna do that.
Yeah.
You got those, all right, I'm with you.
Okay, so we're gonna start with, the first one is the Health Equity Commission. This is one-time funding to support the Office of Health Equity.
And again, what was the total?
250,000 one
Okay,
time.
Okay, thanks.
So look at it compared to the other ones.
These 2 are the highest, these 2 are the highest, these 2 are medium, and then you're just trying to
I
decide.
ranked mine like hours ago and I thought I was so ahead of the game. I made a number.
Yeah.
Well, your number can equate to a highest, higher, medium.
Right, so it's 1 and 2 are highest.
Yes.
3 and 4 are high. 5 and 6 are medium.
You ready?
Yeah.
Okay,
So
so we're doing just Health Equity Advisory Commission
all
right
right,
now,
medium.
okay?
Medium.
Okay.
Yeah.
Medium.
Okay.
Medium.
Okay.
High.
High.
Hi. Did you go?
You got it.
Everyone's gone except.
Did you go on the health equity?
Brian has.
Oh, Brian.
Highest.
Nice. Okay, medium wins out.
Yep.
Okay, so we're gonna add that to the medium. All right, EMS, one time for training.
Medium.
Medium,
Medium.
medium,
Off.
off.
And I'm saying that because I have complete faith in the Vermont Department of Health to figure this out. It felt really chaotic to me in the way it presented. There were numbers all over the place. There, one minute there was 900,000, the next minute there was 90,000. I couldn't follow it. And I feel like we need better information.
I'm with you, Leslie.
So you're off, right?
I'm off.
Daisy's off, I'm off. He's off.
Are we recommending EMS?
Yes.
Training.
Training, not the reimbursement.
Yeah, the training.
Boom medium.
Medium.
I'll say hi.
I'll say hi.
You said hi?
Hi for the EMS training.
Training.
I was hoping we could get it back to 1 million with the COVID fund, but I know that's not on the table.
I already gave you mine.
What was it?
It's whatever you said. Medium, I think.
Yeah, you and
Well,
me.
me with more than first ones.
Yeah, I was one of the first ones that voted.
I said off.
And my reason is I love the training and the EMS, but I think there's a strategy for getting this money elsewhere.
Agreed. Yeah. And there's other sources that they get every year, so I just want to see that. Yeah, I think this
It's
is
not ready for that.
and when they need it, we'll be here.
So off wins, so I'm gonna put it as low.
Yes.
So we take that one right off.
No, we're making it
Make
low.
Just strengthen it.
So the only thing we have left is some language stuff, but people have recommended some different places for language, which Jen is working on. I'll just review what that is. We're going to add language with the embedded mental health workers that we want them to measure the outcomes and work with DMH to ensure that we're working in a coordinated, integrated system of care and have DPS come back to this committee in 2025 with their outcomes. We are adding language, mental health urgent care centers for them to come back also in 2025 with where we are. I mean, they're going to need to anyway if they want money for 2026. But measure outcomes, come back on each specific one where it's working, where it might not be working. We are adding language for the non-emergency medical transportation to let DEVA know it is our intent that they come back with methodology that will keep this mandated entity whole for 2025. And then we have some language that the VNAs and VMS have asked us to do again to ask DEVA to look at some methodology. So if you're okay with Jen and I just doing the language, then we're done. If you all want to review it before I submit it, then you're gonna have to hang around for a couple hours.
There's a strategy.
I have one question.
Yes.
There's a bill that we're gonna take up for testimony that has just a little bit of money in it.
Well, we haven't decided whether or not we're taking up that bill yet.
My question is,
H 818.
yeah, my
I can-
question is, how would that be addressed if we're taking testimony on that bill and
Yep. So what I can do is, there are 3 bills listed because we've already started taking them up. I've talked to appropriations. They just want us include in our letter, or that we're going to do a spreadsheet, that we are still reviewing these bills and there may be money associated with them. And then that's a conversation. Appropriations. Got it. So it can go through its normal process. Good question.
So another moment of obliviousness. Can you just tell me how we ended up in our, the rate reimbursement line? I lost track.
Yep. So VNAs are highest, EMS is highest. Bi-State is high, Vermont Care Partners is high, VMS is medium.
Thank you.
Anything else?
Thank you.
Yeah, thank you all. I mean, this is not ever an easy process. Yeah, it's even harder this year because we know the circumstances, but then there's a lot of need, but I think we handled it well, and I'm glad we heard from everyone to understand where the need is. And we'll, keep fighting for what we have put forth here, but it goes to appropriations now and then it has to go to the Senate.
I'd like to honor all the work that we've done too, like
Yeah.
a big yay for some really big bills, including the BAA, and thank you, Melanie, and all of you,
Well,
Daisy, Lori.
the compacts, yeah.
And, for the budget. But this is big stuff.
Someone said to me today, yesterday, is this one of your bills again? Yeah. They're like, you're rocking it. I'm like, all right, well, that's doing pretty good. So yes, we've done a lot. Yeah, we've done a lot. We have a lot still to get out. And my goal for next week, fingers crossed, is we will have a very late Friday to start the week off because we all deserve it. So
I'm going to California.
great.
Granddaughter.
Late
Yeah,
Friday or
No, I
late-
just
late
want to say
Tuesday?
that, because I know that this is like the heart and soul of so many in our community, that we valued every single thing
Yes.
on this. And so it's like, that goes without saying, but I just want to say it.
Yeah.
It's hard to prioritize, but it's all important.
It is all important, yeah. And people are gonna be disappointed at the end in May or whenever we vote on this. But hopefully we're putting some money where our values are and we'll help as many Vermonters as we can.
100%.
So thank you all for everything.
Did you say, late Friday or late?
Light.
Oh, light.
A light. That's right.
Late Friday.
And I'm saying, wait a minute.
No, next Friday, I'm hoping we can have an early start to the week off. So anyway, so come prepared next week, potentially voting out 3 bills. If not, it will be the week after, and then maybe taking up a couple others and doing other fun stuff. So thank you all.